I want to give a little bit more context for from what Nancy and Anna were presenting, and really try to get into the meat of like what is actually happening at OHCA, and where are there areas that we can engage in to potentially, both opportunities and obstacles that OHCA presents. Oh, sorry, and also everybody refers to it as OHCA. So, I want to kind of broaden our kind of look at what is happening. Some things that could be beneficial for us, like the fact that OHCA claims that they can't create enforceable standards for value-based payments, for alternative payment models and whatnot. But with that, I'm going to share my screen. If you all just hold on 1 second. So just to kind of step back one minute here with OHCA, I just wanted to talk about first, OHCA, Vishal Pagani is a deputy director. They are under HCI, formerly OHCA, the Department of Healthcare Access and Information. They are a new office within HCI. As Nancy said, they had $30 million to start this office last year. For the first few months, they only had 2 employees of the Office of Healthcare Affordability, and right now they have somewhere around 30-ish employees to do this massive work of getting spending targets, establishing regulations on spending targets, collecting data and information from healthcare providers, health plans, and various other healthcare entities on their spending. And then this massive regulatory and administrative work, which includes analyzing mergers and acquisitions of large healthcare transactions. So it's a lot of work that this office is doing. Now, one of the things that Nancy was talking about is that OHCA is trying to create spending targets, and one of the primary things that they're doing is trying to understand and analyze what total healthcare expenditures are. So a lot of the past year has been trying to figure out how do we actually count what is being spent on healthcare in California. And this is the basic formula that they're looking at, which is they're looking at medical expenditures in terms of what claims are being paid, and then what non claims-based payments are being paid for healthcare benefits, and then cost sharing. Now, this is an important piece here because they recognize that spending on healthcare includes cost sharing, but time and time again, they have stated that they cannot figure out how to collect data on cost sharing. So what they've done when they've been trying to analyze total healthcare spending in California is that they've just given up on trying to figure out what cost sharing is, because it's just too damn hard to figure it out, because as plans and providers shift cost onto patients, whether it's through deductibles or medical debt or various types of out-of-pocket spending, it's just too difficult for this office to figure out how to regulate various entities to give them data. And then additionally, they also recognize that there are administrative costs and profits, but time and time again, they, in their analysis of total healthcare expenditures, say they can't figure out how to actually understand what administrative costs and profits are. So this is the pie in the sky formula where they do recognize that patient costs, administrative costs, and profits should contribute to total healthcare expenditures, but they can't figure out how to actually track it. And then similarly, when they're analyzing what are the problems causing healthcare cost increases, you can see in the middle here with number 2, with what is causing the problem, they say price, volume, intensity, population characteristics, but lo and behold, the thing that has fallen out is administrative costs and profits. And then here's another variation of how they've analyzed drivers of healthcare spending. And I'm getting into this just to kind of really emphasize the fundamental problem in what they are doing, which is they're attempting to gather a lot of data in terms of healthcare spending, create benchmarks in terms of both statewide spending on healthcare costs, as well as eventually creating individual healthcare entity spending targets. But then their data is messed up because it excludes very large and important pieces of the puzzle. So even in a perfect system that they're building together in their attempt at creating spending targets, it's just not going to work because, as we all know, profit-seeking healthcare entities, insurers, and healthcare corporations, they will try to hide these costs and shift the costs onto the areas where OHCA is not tracking. And so these are some of the big and overarching concerns that we really want to consider. Just to kind of give you all a sense of the timing. So last year, they really focused on creating the various mechanisms, getting people onto the board, convening the various advisory committees, and then starting to develop regulations. Now, in the past couple of months, they have issued their first set of regulations, which is their cost and market impact review regulations, which is their merger and acquisition healthcare transaction review. But as Nancy said, OHCA does not have any authority to actually block any healthcare transactions. Hopefully this will at least help us get a little bit more information and a little bit more notice before a major merger or acquisition happens. But at the end of the day, OHCA does not have any authority to block the transaction. And the bill that established OHCA did not give the Attorney General or any other state regulators any additional authority to block healthcare transactions. And then importantly, this year, as we've been talking about, OHCA is looking to adopt primary care, APM, and workforce stability standards. And importantly, these standards, as we found out just in the past few months, the standards are apparently not enforceable, and they are really just benchmarks, which is, which I think we can play to our advantage with APMs to use that space in terms of challenging the benchmarks that are being created by OHCA with those 75% benchmarks that they have for years down the line. So I think that is one of the big opportunities that we have, is that because OHCA does not have the staff to actually implement any of these proposed standards on APMs, that we can try to get in the door. Now, importantly, with the spending targets that they're still currently considering, those spending targets, which Nancy talked about just this Monday in the most recent OHCA board meeting, they actually are now considering moving the target to 3.5% because of industry complaints about the 3%. So we're already seeing a little bit of pushback against the industry. Industry had wanted to see 5%, 6%, and then adjustments before the spending targets were actually applied to healthcare entities. So they are looking for opportunities to figure out ways that they can, spend, get more profits, charge more to patients. And really what we're doing for some of us advocates is really trying to make sure that this doesn't become a convenient way for healthcare providers and plans to jack up prices, to shift more costs onto patients, and to to short staff, for particularly for CNA and our nurses. We are very worried that the the spending targets will be shifted. Attempts to meet the spending targets will be shifted onto the backs of workers and to patients. And then the other kind of way of looking at it, here's some of the other regulations and standards that OHCA is looking for. You can see that they're pretty well down the road on the statewide spending targets here on the left, as well as the analysis of total healthcare expenditures in California, and then with the cost and market impact review, which is their merger and acquisition healthcare transaction review. They've already finished the rulemaking process. And then we are kind of in this fuzzy area right now with alternative payment models, primary care investment, and workforce stability, where they're considering standards and they're discussing how these standards actually interact with the statewide spending targets. And just so we're all clear about where they are, we already talked about this, which is the healthcare expenditures. So just so we're clear in terms of how the spending targets are actually implemented, what in theory is supposed to happen is that there will be, at least until 2028, there will be statewide spending targets of somewhere between 3.5%. And they will be looking at each of the healthcare entities to see if they are meeting the benchmarks. Again, these aren't necessarily enforceable at the moment. What happens after healthcare entities report? So sometime around in 2028, there will be some process to assess the performance of each individual entity against the statewide spending target. And if there is some noncompliance with the statewide spending target, or the language that they use in the statute is whether or not the healthcare entity has contributed to the state not meeting its healthcare spending performance targets, then the healthcare entity will be moved onto a performance improvement plan, where there would be, in theory, technical assistance provided by the Office of Healthcare Affordability. There would be some form of public process to engage to talk about why a healthcare entity has not met the statewide spending target. And then there would be some form of performance improvement plan. And then lastly, there would be some sort of administrative penalty imposed. Now, where the workforce stability standards, where the APM standards, the primary care standards, the behavioral health standards come into play, at least as what OHCA is saying right now, would be in this process, where looking at the performance improvement plans or the assessing performance against the spending target, that those standards would somehow allow for some adjustment for that individual entity in terms of enforcement. Either they need to the technical assistants could say you need more APMs, or the technical assistants could say, well, you went above and beyond your primary care and behavioral health spend, your spending benchmark, so we will give you an adjustment and some leeway in terms of not meeting the spending target. So it's very vague right now. I know I'm not really explaining this very clearly because I don't think anybody knows. And I think this is another one of the opportunities that we have here is to really push back against the use of APMs in this process of enforcement and progressive enforcement actions against healthcare entities, because we cannot have APMs being used as a measure to correct for healthcare overspending by healthcare entities. So I think this is generally where the space where we can most be impactful. Now, I want to kind of just briefly touch on to a couple of um, uh, the issues here with how this is going to work in terms of reporting and adjustments when trying to meet the health the statewide spending targets. Here you can kind of see the timeline that they've outlined for now. Of course, all of this is a little bit adjustable. So they're going to be getting reports from individual entities for the first few years, and then they won't actually have progressive enforcement until late 2028. And there really is a number of years of wiggle room before any enforcement happens. So this is one of the big questions that has been coming up in the meetings with the OHCA Advisory Committee is, should the targets be adjusted? When should they be adjusted? How should they be adjusted? This is just one of the questions that has come up about whether they should be adjusted for the healthcare entities population. I think you all are very, are very familiar with how risk adjustments happen on an individual provider level. So this is kind of the same idea that OHCA is trying to overlay onto the statewide spending targets. And with adjustments, they're still looking at very specific types of adjustments, and there is this ongoing debate about what would be the effect of things like adjusting for age and sex, or adjusting for other clinical variables for each healthcare entity. You all can see this. I know that we can probably send these around, but if you start looking at the OHCA board advisory committee and the investment and payments advisory committee materials, you'll see more and more of this, where there's this really deep discussion and debate happening behind, with OHCA staff, about the advantages and disadvantages of various types of risk adjustment. And just to be honest, when it comes to the actual advisory committee meetings, to the actual board meetings, it's very difficult to have a meaningful conversation, because these ideas are just being presented to us as members of the advisory committee, the members of the board. So if we don't have powerful voices at the table, then oftentimes a lot of these discussions just disappear, because there's very little time to actually get into the meat of of what is happening. Another type of adjustment that they are statutorily required to do is organized labor adjustments, so that at least if a provider is trying to meet the statewide spending target, that they will not cut costs to the wages and the benefits of unionized workers. So this has become a very interesting discussion, because anytime the organized labor adjustment comes up, the employers that employ non-union workers, they like to say, well, why can't we have an adjustment upwards too, so that we can charge more money and spend more, because if one hospital has unionized nurses, we want to pay our nurses the same amount, so therefore give us an adjustment upwards. Now, obviously, for any of you who have participated in labor organizing, that's just a way for employers to try to be able to profit off of the fact that from their union busting, because they would like to raise their prices without actually having organized labor in their workforce. Now, part of the adjustments, there's also this question of about workforce stability. There are very concerning things about the workforce stability standards that Nancy touched upon. One of the things that they have said that they want to insure against is the reduction in staffing, particularly healthcare worker staffing to meet the spending targets. And frankly, the way that their proposed standards are written, they really are looking for ways to use technology and AI and other types of short staffing models to shift care into lower cost settings and to reduce the number of staff that are available to provide healthcare services, to shift care from licensed professionals to unlicensed care, pushing care to families and into communities. Things that seem good on paper to a lot of people about having more care in the communities, but ultimately we know what healthcare providers will do. They will try to push the actual work of healthcare and clinical work to the lowest cost healthcare worker with the least amount of licensure or professional judgment. So really, it's concerning that they're supposed to be watching out for this, but ultimately, I think they might be allowing for healthcare employers to cut corners when it comes to to the actual provision of care. I'm going to skip this just because there's a lot going on with healthcare workforce stability standards. Now, just back to the APM standard. So a lot of the work being done and discussion on APM is in this investment and payments work group. That is a separate advisory work group of the Office of Healthcare Affordability. And as you can see, there's a lot of wide-ranging types of folks on the investment and payment work group. And I think one of the big things that I think is important here is both on the advisory committee and this investment and payment work group, there are opportunities for folks like you to be able to apply to be on these work groups and advisory committees. Now, neither this work group nor the advisory committee have caps on the number of people that are on the advisory committee or the work group. There is an open application process right now for the advisory committee. It's not entirely clear if everybody who is currently on the advisory committee will continue to be on the advisory committee. There's a number of us who have to resubmit our application just because they establish staggered terms. So this is an important place where you all can try to start participating in the OHCA process. I think these last two slides are just about primary care and behavioral health, which are very similar to all the other adjustments that we talked about, where there aren't real standards, they're just benchmarks for the extent of the provision of behavioral health and primary care. But with that, I'm just going to stop sharing right now and just kind of go over my thoughts about like what we should try to do and what we should expect from OHCA moving forward. Let me make sure that I can stop sharing. 1 second. So I think one of the important things to know about OHCA is that we really, it's in statute right now. They are going through the motions of putting all this work together, creating all these standards. And I think what we can expect from OHCA is that a lot of these ideas and this infrastructure that they're making with all the payers and plans involved in the Office of Healthcare Affordability process, that they're really going to, they're they're really going to try to uh, they're going to try to use this to overlay it onto a single payer system, because it's an existing infrastructure. Clearly, the problem is that insurers are already at the table. I think for us that's obviously very problematic, because we don't want insurers to be in this discussion or be a part of any type of attempt at getting to a single payer system. So that's a really big concern of ours. I do think one of the other interesting aspects of this is that the healthcare providers and the payers themselves, so the plans and the healthcare providers, are at odds with each other because they are blaming each other for the increase in costs in healthcare. And you can see where they are trying to shift the blame on each other. And it could be a good source of information to ensure that we can figure out how much money is actually being spent for healthcare plans and administration of healthcare plans, and how much is actually being pocketed by providers and plans for profit. Now, obviously, this is only going to be as good. This data collection role of OHCA will only be as good as their ability to collect that data. And this is where it's unclear whether or not they're actually going to get good data from any of these entities. And as Nancy was saying before, this is a huge administrative burden. And the hospitals and other health plans, they've already been talking about how much all of the reporting will increase the costs of administration. The Kaiser Permanente representative on the advisory committee often likes talking about how they'll have to hire armies full of insurance adjusters because and actuaries, because they will need to have to figure out how to report the data and figure out how they can make sure that they're meeting the spending targets. So I think there's a lot of concerns here with both OHCA itself and their goals, as well as what it could mean for our single payer fights in the future. I think what it could also prove is that simply trying to use market economics to reduce healthcare spending will not work. And I think that's really important because we're not looking at administrative costs. We're not necessarily looking at reducing profits, despite the fact that me and some other advisory committee members continually try to raise the issue of administrative costs and profits. Sometimes it's just, we're just saying talking points to OHCA staff that are too busy and too overworked to even take it into consideration. I do think there are a lot of opportunities to engage, but it will be a tedious process. I'm not going to sugarcoat it here. They've created this administrative monster on purpose where it takes hours and hours of time to even engage in these processes. They have, as always, hired consultants. Right now, they are using the UCSF Health Force researchers as their primary consultants for a number of the standards that they are developing. The consultants, as well as the OHCA staff, they are doing some "quote unquote" stakeholder meetings, and it would be important for doctors, other single payer activists, to try to get into that list where they talk to stakeholders, where you are at the table. And ultimately, I think this is really important in terms of building that relationship with California regulators so that when we get a single payer system, that we are ready and we are engaged with the infrastructure within the state to make sure that single payer is implemented in the ways that we know it should be implemented, and there are no compromises. I know we're already past 8, so I'm going to stop there so we can answer questions. I think this goes to Amber now.
Yep. Thanks, Carmen, and Nancy and Anna. Those were great presentations. We have kind of a two-part question in the chat that I'll relay, and then if anybody else has a question, they can raise their hand or type in the chat. So Steve Vernon wants to know, what is the CalCare relationship with OHCA? AB 2200 talks of sending data to OHCA. Given all that has been said tonight, it's clear that their approach is not a good idea. What is the expectations of being able to turn this around? And then there's a much longer piggyback to that regarding OHCA and CalCare, which if you want to read it in the chat and maybe respond to both. Apparently, Ian Lewis, who was on the OHCA board, was interviewed in response to the question. CalCare, a new California-based single-payer bill, will be introduced in the state legislature this year. So what's at stake this year in terms of healthcare affordability? In his response, in terms of that work and making it real, I would highlight a bill that was passed in 2023, SB 770, which has set the ball in motion to design a Medicare-for-all system in partnership with the federal government. You know, creating that system is a hugely complicated enterprise, and as I said, it's going to require a lot of negotiations and discussion with the federal government. And there are some big questions that should give us pause if the federal government is not going to support a particular way of doing things. We really have to evaluate if that's the right path to go down in California. And so what's exciting about SB 770 is that we're actually going to find out in the next 12 to 18 months what the Biden administration and the federal government is willing to support and what it's not willing to support as California designs its own health system. This leads me to believe that OHCA is explicitly pro SB 770 and anti-CalCare. I'd love to hear your thoughts.
Yeah, I think, you know, just on the specifics of where OHCA stands on CalCare or SB 770, there was a moment in one of the advisory committees where I kind of just started saying, they started talking about APMs, and I said, well, you know, the best way to save costs is to move to a single payer system, and you know, and I gave a criticism of APMs, and then I believe Parker Duncan asked about where the administration was at on SB 770, and they looked like deer in the headlights and very clearly decided not to respond to either. So I think their marching orders are very clear that they don't take any positions on either SB 770 or CalCare. Now, on the question of data being sent to OHCA, so just to be clear, so in AB 2200, data would be sent to the Department of Healthcare Access and Affordability, and not necessarily OHCA. So HCI itself is generally the holder of healthcare data. They are responsible for getting any healthcare data. You know, when hospitals do reports on various information, that usually goes from hospitals to HCI. So there's no intention of having OHCA play any role. It's intentional that we're not doing that. I think maybe it's being confused with the Office of Health Equity, which is a new office that we would create under AB 2200, which would not have the same goals or purposes of OHCA. You know, the Office of Healthcare Affordability would be looking specifically to figure out and create programs to address gaps in healthcare, health equity, and healthcare disparities, which importantly, OHCA does not have that role, which I think goes back to Nancy's question about will OHCA spend any money on investments on behavioral health and primary care? The answer is probably not, because that's not their role. Isn't to provide grants or programs or investments. They are just there to say, hey, healthcare provider, health plan, you should invest in primary care and behavioral health. So I think that's a really big distinction to make. And you know, let me see. I think Nancy, Anna, do you have anything to add to any of the those questions about um, uh, that Amber read out?
Or Stephen and Caroline, do you have any other comments related to your questions? If not, we have a few hands raised. No? Okay. Kip Sullivan, you were the first one.
Yes, I'm just for those of you who don't know me, I live and work in Minneapolis, and I'm watching with great trepidation the progress of this board. Minnesota legislature, the year after your legislature enacted the Affordability Board legislation, enacted a nearly identical bill in the 2023 Minnesota legislative session. And it was only because of the Mayo Clinic's threat to leave the state at the last minute that the bill got watered down. But very vague language was nevertheless enacted. And now we've got our Minnesota Department of Health doing, we will see how much the Minnesota Department of Health tries to mimic what the California Affordability Board is doing. I think that and so I'm trying to anticipate how to keep our Department of Health here in Minnesota from going down the route that California has gone. And I'm cheering for all of you to figure out how to stop this train wreck. And it seems to me the train wreck is inevitable. And Carmen has summarized the main reasons. And I want to ask Carmen if it's possible to get the Affordability Board to simply simulate now, not wait until 2028, but go through the process now of setting expenditure caps on 300 doctor groups, 400 hospitals, 33 health plans, never mind skilled nursing facilities and a whole lot of other providers that are not included in that list. And imagine trying to come up with a performance improvement plan, a PIP. They will be working off of white noise. Everybody will be working off of white noise for the reasons Nancy and Carmen have already mentioned. Risk adjustment is absolutely worthless if you only rely on age and sex. There is no attribution problem with the health plans. You enroll in a health plan. But California residents will be attributed to hospitals and clinics based upon what I understand, same lousy, stupid method that CMS uses to attribute Medicare beneficiaries, which is prior use of a primary care doctor. And there's this cost sharing problem that I'm not surprised, but we now hear from Carmen that they can't solve the problem. I have a hard time imagining how they will. So these 8 people running the Affordability Board should, I think, now ask themselves, shoot, let's just see if we can't imagine how we're going to detect whether all of these entities went over their target, and then whether we have a clue why they did and what a performance improvement plan would look like. And if we don't have a clue now how to do that, why don't we just tell the legislature, you guys blew it, you should have thought this ahead of time. So I repeat my opening question, is it possible to get the Affordability Board to simulate now, not in 2028, what it's going to be like to try to determine a cap on each of these entities that it's supposed to regulate?
We could try. I will say that the folks who are on the Healthcare Affordability Board are. I would be shocked if they would, just as a kind of point of information here. So, obviously, Dr. Galley, the Health and Human Services Secretary, he's not going to want to, end something. And he is always prone to not saying anything about whether a bill or a statutory regulation is a statutory requirement of his agency is good or not. So the chair himself is likely not to do that. I will say, so Dr. Pan, who has been a loud voice on the Office of Healthcare Affordability Board, was one of the architects of the bill itself, with Assemblymember Jim Wood, when Dr. Pan was in the Senate when OHCA was being developed in the legislature. So I think, there's a lot of resistance, I think, that we will see in trying to unwind this through the board itself. And I think, but that I don't think that means that we give up. I think a good example, on Monday's board meeting, the Carpenters Union had a picket outside of the OHCA board meeting because OHCA continues to fail to meet its it's clear. The Carpenters have a very specific campaign against Kaiser increasing rates for their health and welfare benefits trust for their union healthcare plan. And in theory, something should be happening, and OHCA should be trying to ensure that healthcare premiums don't rise dramatically, that that workers are losing their healthcare coverage, and they're not doing anything. And the Carpenters are worried about Kaiser doing, as well as CNA, cross-state, cross-market mergers and acquisitions by buying health systems outside of the state of California. And those things should be on OHCA's plate. So I think there's already starting these grumblings of OHCA's not even doing the basic thing that they need to do, and it may be a lost cause. And I think that is a narrative that we should be pushing, and really trying to say, like, these spending targets aren't actually going to do anything, and trying to emphasize that if they're not going to actually do the work of identifying the administrative costs that are being spent, the costs that are being shifted onto patients, the costs that are being cut by cutting healthcare workforce, and all the like, everything that we've been talking about tonight, then their primary mission of creating spending targets that are enforceable will just fall to naught, because if they can't do these basic things, there's been a lot of, we don't know how to do this, and I think that's coming out as we're talking about how they actually implement the performance improvement plan, because everybody is confused. I actually said this last week in the OHCA advisory committee, which is just like, I don't understand how you're getting from A to B, and how do we get to the point where we're actually having public accountability on what hospitals and health plans are actually spending, because at the end of the day, that's the thing that will help us as single payer advocates, is actually calling the question about where's your money going, both for health systems and plans. That's not really answering it. So kind of to answer your question, Kip, is we can push, and I think it's important to do so. I don't think this particular board will actually appease any of us in trying to change their statutory charge, but
maybe
it's
the simple
worth
thing
to try.
Maybe the simple thing to do would just say, don't you anticipate having to set a cap on each of these entities? Why don't we? Can we do it? Can we do a dry run now, or must we wait till 2028? I won't take up any more time, but it seems to me you can pose a yes or no question.
Gary?
Yeah, hi. So first of all, thank you all for these wonderful presentations. They're excellent. I want to make a brief comment about what Kip just raised. And I think what he's really saying, it's an excellent comment that he made. I think what he's really saying is not that you can get them to do this, but by merely suggesting that they can't even try to begin to do it, that there's no way to do it, even now, no less 5 years from now, you already established that the process is ridiculous. So I think it's a good idea to force them to face the fact that they can't possibly do this. But the longer comment I wanted to make is a different one. First of all, there's no question, as you suggested, that this plan is horrible and that it's doomed to failure, and it's really in the service of for-profit entities, and that the big problem with the huge amount that we spend in America is profit-generating activities. And those include the vast administrative costs, and they also include prices. But I think several of the speakers made a substantial factual mistake when they suggest that overuse is not also a generator of enormous unnecessary costs. More important than costs is it's a generator of enormous unnecessary harm. There's a huge literature about this, even if some of it is not about analyzing in a formal economic way exactly how much money is spent. There is literature on that. The IOM suggests that we're talking about billions of dollars of cost, of waste, but even if you don't go along with the IOM message, there's a vast literature in many, many areas of medicine, of healthcare, suggesting that we do very inappropriate things all the time. Let's be really careful to understand that we also do underuse the same exact things in different populations. What is often called our healthcare system is not a healthcare system, it's a marketplace. And in the marketplace, we sell to people who can pay, and we don't sell to people who can't pay. So there's lots of underuse and lots of overuse. We don't have time. We could have a whole session to go over the evidence that cardiac stents, a many billion-dollar industry, are done at least 30% of the time and probably 50% of the time. And that's using cardiologist standards, which are very biased, in patients who cannot stand to benefit. There's a vast literature about use of interventions in back pain that is completely useless, and in knee surgeries, and in advanced imaging, and in diabetes, a $1 trillion industry where all of those things that you do to measure and to measure blood sugar and devices, etc., do not help in patients with type 2 diabetes, which is the vast amount of diabetes. And 3/4 of antibiotics used in upper respiratory, for outpatient disease are misused because they're used for viral upper respiratory infections. There's this vast literature. I don't think you need to say that overuse is not a problem in order to defend the notion that these alternative payment models are bad. And I just finally like to add that that the notion that this is all about greedy doctors and we should reject that is a silly one. It has nothing to do with greed, it has to do with human nature. Sinclair Lewis said a century ago, it's very difficult to get a man to understand something when his salary depends upon his not understanding it. I think most of us understand that that's true. We understand that's true when the drug companies pay doctors or give doctors little things to incentivize them. They overuse the drugs enormously. There's many, many examples of this same thing. It's human nature that when you incentivize somebody economically, they change their behavior. So this is not about bad doctors, but we should not reject the idea that that overuse is important and that it's driven in great part by for-profit industry, which influences the way that the doctors behave. That is no way important against the notion that these alternative payment models with their vast infrastructure is a bad idea.
Jeff Gordon, you're next on the dock, and then we have some questions.
I'll try to be a little bit briefer. First, congratulations to everybody who made a great presentation. I have to say, I learned a tremendous amount. I would criticize Anna because it's not a hamster wheel. This looks like a bear growling out of a deep cave, spitting fire. I mean, it is absolutely mind-boggling. And I would point out two things. Carmen mentioned it kind of in passing, but the scary thing about this is the incredible administrative burden it's going to impose on every healthcare provider of any size. The cost of responding to any of these data requests is literally going to be quite substantial. And that's a sucking away of money from healthcare, if not profits. I would remind people that it's now about 10 years that the Affordable Care Act came to California as California Care, but few people realize to implement that system from enrollment through providing care in California required a subsidy of $1 billion. And this system looks like a much larger effort than that. The last thing I will say is because of its inherent unitary nature, if this kind of supervision is imposed on the healthcare system, Kaiser is going to be the most vulnerable because it's going to be the most able to provide any data that matches the needs that you've described, and they're going to be the easiest to target to suck sanctions or afflict them with sanctions. And to me, that's a scary turn of events.
All right. So one thing that's come through in the conversations is around costs of what's being charged, but I haven't heard anybody mention the true cost of care. And in my experience, that's a very difficult metric for hospitals to report. And what is there any conversations in OHCA around a centralized database for the true cost versus what's being charged and sort of profit margins? There's a few comments in the chat around monitoring profit margins and hopefully leaning towards a non-profit version of this, but in order to get there, you got to know what things cost.
I don't mean to interrupt, but doesn't OSHPD collect that data?
The true cost of care, like
Yes.
what everything actually costs to make?
I thought they transitioned to that 4 or 5 years ago.
I think so. Jeffrey, I think you're referring to the health payments database. So a few years ago, they did start to implement the health payments database, which is supposed to collect the information about health payment claims, the cost of those claims by insurer, by plan, by provider type, and in theory, also attempt at figuring out what the actual costs of care are. But I think as Amber was talking about, it's very difficult for that to actually be captured. And I know that the HCI, formerly OSHPD, they have just released their first kind of beta version of some data that their test data that they got from the health payments database. But just kind of what I've heard from folks who have been working on that and trying to collect that information, they are at least 5 years out before getting any real even claims payments accurately reported year after year. So they are significantly far out in terms of reporting that information, and then potentially another couple of years down the line before they even try to attempt to make sure that they're actually looking at the actual cost of care. And I think, long story short, like, these are long-term processes where we already know what the answer is that there's too much money being spent on administration and being pocketed as profit. I think it's the fundamental question of some folks who have tried to say that this project of both OHCA and the data collection on the healthcare payments database will help a single payer system in the long run because we'll understand what the costs of care are. But, you know, at the end of the day, we have to ask the question, is this actually just delaying us because we're trying to perfect the data? You know, because we need to move to something, you know, we can't wait and wait and wait until we perfect the data in order to prove that actually the cost of care, if we actually are just paying for the cost of care, that we can save the state money, as well as patients, or we can try now. So I think that's kind of the tension with what's happening with this data collection project, which is that we can't have it be an excuse to not get us to single payer. But you know, Amber's point is really clear, which is like, will this actually have the teeth to be able to get that information from providers and plans? And I think the answer is no.
There's a couple questions around other developed countries' health models. Is that something that OHCA is considering in their data collection and design? Are they looking at what works in systems like Canada and England? Somebody mentioned that one of the leaders came from the German system. So are they looking at how some of those countries are managing costs and collecting data?
There's only been the slightest discussion of other countries. They've been primarily looking at the other states that have implemented similar spending caps and spending targets. It could be something that they could look at, because obviously if we start looking at other countries, particularly countries that are single payer countries, then the discussion might broaden. But primarily the comparison has been to other states.
Okay. Kathleen Healy has her hand raised.
Yes, Carmen, I think from what I understand, one of the objectives of the commission is to look at the profits that the insurers are making from healthcare in California. And I think I heard you say that the office doesn't really know how to measure it, so they're not measuring it. I mean, this is a huge portion of the cost of healthcare. So is there any way they can be pressured to try to look at profits these companies are making?
Yeah, no, I think that's a great question. I mean, like, in theory, they're supposed to be understanding what administrative costs and profits are. They're not trying at the moment. I think where this has come up, and where we can try to push them to actually figure out what is being spent on administration and profit, is in this enforcement part, which is if there's a healthcare entity, whether it's a provider or a plan, that goes above the spending caps, then they are in theory subject to some additional scrutiny, and that's where OHCA is currently discussing, looking closer at the books of a provider or a health plan. And I think this is where, if we actually want to have some benefit to OHCA's project, we can say, there in theory is a public accountability process with public hearings. And I think this would be a good opportunity to say, we actually want to know how much you're spending on profit and how much care you're denying, and trying to figure out that question, because it would help to understand really if price increases are just being pocketed by health insurers and the large health systems.
Two more hands up, and I think that'll be it, because then we're kind of already at an hour 40. Barbara?
Yes, hi. There is a way to measure profit for ourselves. You can look at this at Wall Street. Healthcare sector is number 3 on the list. It's like, and ever since the Affordable Care Act passed, the graph shows it going straight up. So it's in everything. It's in public pension funds like my CalPERS. heavily invested in healthcare and also in healthcare private equity. Okay? It's amazing. And it's probably in every other state's public pension fund too. I suggest a good, healthy stock transaction tax on all health stocks to help us fund our national health system, or a campaign to divest from healthcare and put your capital in climate control, a much more socially responsible entity. So just a couple of thoughts on that. And thank you to all the presenters. This has been a really informative panel discussion. Thank you.
Corinne?
Thank you. Yes, thank you. The presentations are amazing, Nancy and Anna and Carmen. I have two questions. One is, if in the ideal world a single payer system was passed in California that mandated fee for service as a payment, which one would supersede, the Office of Healthcare Affordability rules or the single payer system? That's one. And two, Carmen, are you the only voice that thinks like you do, or are there any other people on the board, either the advisory board or the top board, whatever you call it, who think like you?
So on your first question, what happens to OHCA? I think if single payer is passed, I think, ideally what would happen is that the insurance monitoring and administrative function of OHCA falls away, because there would be one insurer, and they would only have one. And I think I've said this before about the Department of Managed Healthcare. When single payer is passed in California, it'll just make the regulator's job easy, because there would only be one plan to monitor. So in theory, that is what happened. I know, I know the insurers will fight tooth and nail against that. I think this is a something that clearly we need to be able to address head on at some point. And I do think that there are parts of OHCA that are salvageable, like the mergers and acquisition review. That's really important, because we don't have full information about, just generally private sector healthcare mergers and acquisitions. But yeah, so that's what I think might happen if single payer is passed. And then in terms of other folks on the advisory committee and the board, I know that Parker Duncan is a single payer supporter. He kind of got a glint in his eye when I started talking about single payer. So, there are other advocates, but it's very hard in advisory committee meetings. There are 27 of us on the advisory committee. So anytime that we talk, we only have maybe a minute or two to say our piece and try to hope that we get as much in there as we can. So it's a difficult process. I think, for you all, I think what's really important, because I think some folks were asking, like, does picketing work? I think what really works is at least showing in full force in those meetings and commenting. So, like, to take it from the some of the groups that have been engaging with OHCA, they'll have a set of comments ready. There's a general public comment at the end, and then there are specific public comments throughout meetings about the specific agenda items. So if value-based payments is up, it would be great to have a lot of people ready to give comments on value-based payments. Or you could just take the open public comment at the end to talk about a very specific topic. And I think those are really effective ways on getting messaging out, because, some groups have been doing that, which is saying, why isn't OHCA doing this? Why is OHCA doing that? And really questioning the fundamental structure and framework and process of OHCA, which I think is important to get out there. But as I said, there's a lot of meetings, and it's really difficult. And just being in the advisory committee, they're really tiring. So I will say, they're extensive processes, and I know a lot of people, folks are trying to do their best at listening to some of the comments, but I think repetitive comments to the board is really a way to be effective. Writing letters to the board is effective, particularly if there are public comment periods. I believe there should be a number of them coming up for the APM standards soon. I know that there'll be more on the spending targets themselves, as well as on the proposed workforce stability standards. So there are a lot of ways to engage, and it's chipping away at it a little by little, and I think that's really what we have to do here.
Thank you.
All right, I think we're wrapping up. If there's any other burning comments or questions?
I have a quick question for Carmen. I think I read somewhere that you suggested you were concerned whether it was actually worth spending all the time on the advisory committee because of how stacked it is, and I'm wondering whether there really is a purpose. Maybe if a whole bunch of us tried to join, but is this really something worth spending a lot of time to try to be on that advisory board? I
ask myself that question all the time about whether or not it's worthwhile sitting in the room with a bunch of health insurers and hospitals, trying my best to stake the draw the line and try to push back on them. And speaking of hamster wheels, it sometimes feels like that. I do think there may be a good strategy here in terms of making sure that the basic comments are given to the Office of Healthcare Affordability, and then trying to take that to a higher level and really either trying to talk to legislators to change the actual statute itself and the role of the Office of Healthcare Affordability, or to try to take it up to Secretary Galley. But I think, I think it may be a worthwhile endeavor to at least try to see if they are responsive. At this point, it's I think give them one shot, and if they fail, then escalate to a different level.
And you said it's 4 quarterly meetings, correct? And they're currently applying for the advisory board?
Yes. So the advisory committee has quarterly meetings. We have talked about having more meetings at various points. The office, the board itself meets monthly, and then the investment and payment work group, they meet a little bit more. They've been meeting a little bit less than monthly, but you can also see, I'll put the link in here for the investment payments group meeting. And then there are also links to apply to the advisory committee somewhere on their website. I know it's a clunky website. So those should all be up there.
You're muted, Nancy.
I was going to say that if anybody wants to apply to be on the advisory committee, the deadline for application is April 1st, so it's almost here. Anyway, thank you all for attending. Thank you, Carmen. Thank you, Anna. I'll have to say I listened to the last board meeting, was the first one that I listened to, and if there was anything that made me more convinced that we need a single payer system, it was listening to that and realizing how much this huge administrative apparatus that they're engaged in, and how it's so unnecessary. If you want to control costs in a hospital, give them a global budget and not have all this reporting going on. Anyway. Thank you all, and the recording will be available to you. And Anna and Carmen, if you could send me your slides, we'll make those available too. Okay. Thank you all.
Recording stopped. Thank you for putting this together.
Thank you for the inspiration.
All right, take care. Bye. Thank you, Carmen, too.
Thanks, guys.